Question 1. The assessment process reveals a 45-year-old male patient undergoing elective orthopedic surgery. During induction of anesthesia with sevoflurane and succinylcholine, the anesthetist observes a sudden and unexplained increase in end-tidal carbon dioxide, ECO2 from 4.5 kPa to 7.0 kPa, accompanied by a rise in heart rate from 70 to 110 beats per minute and generalized muscle rigidity. The patient's temperature is noted to be 38.5 degrees C and rising. Which of the following immediate management strategies is most appropriate in this situation? Option A. Immediately discontinue sevoflurane and succinylcholine, administer intravenous dantrolene, hyperventilate with 100% oxygen, and initiate active cooling measures. Option B. Administer a bolus of a neuromuscular blocking agent to overcome the rigidity and continue with the planned anesthetic. Option C. Increase the concentration of sevoflurane to improve muscle relaxation and reduce the observed rigidity. Option D. Continue sevoflurane at a reduced concentration and monitor ETCO2 closely, while preparing for potential muscle relaxant reversal. The correct answer is A. Immediately discontinue sevoflurane and succinylcholine, administer intravenous dantrolene, hyperventilate with 100% oxygen, and initiate active cooling measures. Explanation. The assessment process reveals a scenario that is professionally challenging due to the immediate and life-threatening nature of malignant hyperthermia, MH. The critical requirement for anesthetists is to recognize the signs and symptoms rapidly and initiate appropriate management without delay. This demands a high level of clinical vigilance, knowledge of MH pathophysiology, and familiarity with established treatment protocols. The European Diploma in Anaesthesiology and Intensive Care, EDAIC, examination aims to assess these competencies, ensuring that candidates can apply theoretical knowledge to practical, high-stakes clinical situations. The correct approach represents best professional practice because it prioritizes patient safety by adhering to established guidelines for MH management. This includes immediate cessation of triggering agents, administration of dantrolene, supportive care, and consultation with MH experts. Such a protocol-driven response minimizes the duration of the hypermetabolic crisis, thereby reducing the risk of severe complications such as rhabdomyolysis, hyperkalemia, cardiac arrest, and death. Adherence to these guidelines is implicitly expected within the European regulatory framework for anesthesia practice, which emphasizes evidence-based medicine and patient safety standards. While specific EU directives might not detail MH management protocols, the overarching principles of patient care, professional responsibility, and the duty of care inherent in medical practice, as understood within the European context, mandate such a response. An incorrect approach involving delayed recognition or management of MH would represent a significant failure in professional duty of care. For instance, continuing with volatile anesthetics or succinylcholine after the onset of MH signs directly exacerbates the condition, violating the fundamental principle of primum non nocere, first, do no harm. Failure to administer dantrolene promptly is a critical omission, as it is the only specific antidote and its efficacy is time-dependent. Similarly, inadequate supportive care, such as failing to address hyperthermia, acidosis, or electrolyte imbalances, would demonstrate a lack of comprehensive clinical management and could lead to irreversible organ damage. These failures would be considered breaches of professional conduct and potentially fall under negligence, as they deviate from accepted standards of care expected of a qualified anesthetist within the European healthcare system. The professional decision-making process for similar situations should involve a structured approach. 1. Immediate recognition of potential MH signs, e.g., unexplained tachycardia, hypercarbia, muscle rigidity, hyperthermia. 2. Rapid cessation of all known triggering agents, volatile anesthetics, and succinylcholine. 3. Administration of dantrolene as per protocol. 4. Initiation of aggressive cooling measures. 5. Correction of metabolic derangements, acidosis, hyperkalemia. 6. Cardiovascular support. 7. Communication with the surgical team and senior colleagues. 8. Documentation and post-event review. This systematic approach ensures that all critical steps are taken promptly and efficiently, maximizing the chances of a positive patient outcome. Question 2. Strategic planning requires a comprehensive approach to patient assessment prior to anesthesia, considering a scenario where a patient presents for elective surgery but has significant cognitive impairment and is unable to articulate their medical history or preferences clearly. What is the most appropriate strategy for obtaining the necessary information for safe anesthetic management? Option A. Prioritize obtaining a detailed medical history from available family members or caregivers, reviewing the patient's medical records thoroughly, and conducting a focused physical examination targeting potential airway and cardiovascular risks, while acknowledging the limitations in direct patient input. Option B. Proceed with a standard, albeit brief, physical examination and administer anesthesia based on general protocols, assuming that any critical information would have been documented in the patient's medical records. Option C. Rely solely on the patient's nonverbal cues during the physical examination to infer their medical history and anesthetic risks, without seeking external information. Option D. Postpone the procedure until a time when the patient is more lucid or a dedicated medical interpreter can be present, even if this causes significant delay to the elective surgery. The correct answer is A. Prioritize obtaining a detailed medical history from available family members or caregivers, reviewing the patient's medical records thoroughly, and conducting a focused physical examination targeting potential airway and cardiovascular risks, while acknowledging the limitations in direct patient input. Explanation. The scenario presents a common challenge in anesthesia: obtaining a comprehensive patient history and performing a thorough physical examination when faced with time constraints or a patient with communication difficulties. The professional challenge lies in balancing the need for complete information to ensure patient safety and optimal anesthetic management with the practical realities of the clinical environment. Careful judgment is required to prioritize information gathering and adapt examination techniques without compromising the quality of care. The correct approach represents best professional practice because it adheres to the fundamental principles of patient-centered care and the ethical obligations of anesthetists as outlined by European anesthesia professional bodies and guidelines relevant to the EDAIC. This involves a systematic, yet flexible, approach to history-taking and examination, utilizing all available resources and communication methods to elicit crucial information. It prioritizes patient safety by ensuring that potential risks are identified and mitigated. This aligns with the ethical duty of beneficence and non-maleficence, ensuring that the anesthetist acts in the best interest of the patient and avoids harm. An incorrect approach that relies solely on a brief, superficial history and examination, or one that fails to explore alternative methods of communication when a patient is unable to provide a history directly, represents a significant regulatory and ethical failure. Such an approach could lead to the omission of critical information, such as allergies, previous adverse reactions to anesthesia, or significant comorbidities, thereby increasing the risk of perioperative complications. This directly contravenes the duty of care and the expectation of diligence and competence expected of a specialist anesthetist. Furthermore, failing to involve family members or caregivers when a patient cannot communicate effectively could be seen as a breach of the duty to obtain informed consent and to provide comprehensive care. The professional decision-making process for similar situation should involve a structured assessment of the patient's condition and the clinical context. This includes 1. Identifying immediate life threats. 2. Assessing the patient's ability to communicate and comprehend. 3. Determining the urgency of the procedure and the time available. 4. Systematically gathering essential historical data, e.g., airway, allergies, medications, previous anesthesia, significant medical conditions. 5. Adapting the physical examination to focus on relevant systems based on the history and planned procedure. 6. Actively seeking information from alternative sources, e.g., medical records, family referring physician, when direct patient communication is limited. 7. Documenting all findings and the rationale for any deviations from a standard approach. Question 3. The evaluation methodology shows that for a patient presenting with severe COPD requiring elective lower limb surgery, the anesthetist must select the most appropriate regional anesthetic technique. Considering the patient's compromised respiratory status, which of the following regional anesthetic approaches would be considered the most professionally sound and safest option? Option A. A caudal epidural anesthetic. Option B. A thoracic epidural anesthetic. Option C. A spinal anesthetic. Option D. A combined femoral and sciatic nerve block performed under ultrasound guidance. The correct answer is D. A combined femoral and sciatic nerve block performed under ultrasound guidance. Explanation. Scenario analysis. This scenario presents a common clinical challenge in regional anesthesia, where a patient's specific physiological state and pre-existing conditions necessitate a tailored approach to block selection. The anesthetist must balance the need for effective analgesia and surgical conditions with the potential risks associated with different regional techniques, particularly in a patient with compromised respiratory function. The challenge lies in accurately assessing the risk-benefit profile of each block type in this unique context, ensuring patient safety remains paramount. Correct approach analysis. Selecting a peripheral nerve block for the lower limb, specifically targeting the femoral and sciatic nerves, represents the best professional practice in this scenario. This approach is favored because it offers profound sensory and motor blockade of the limb, while minimizing systemic absorption of local anesthetic and avoiding potential respiratory compromise associated with neuraxial techniques. The EDAIC framework emphasizes patient safety and the judicious application of anesthetic techniques. Peripheral nerve blocks, when performed with appropriate ultrasound guidance and patient selection, offer a predictable and controllable block with a lower risk of systemic complications compared to spinal or epidural anesthesia in patients with respiratory compromise. This aligns with the principle of choosing the least invasive and safest effective technique. Incorrect approaches analysis. Choosing a spinal anesthetic would be professionally unacceptable. While effective for lower limb surgery, spinal anesthesia involves injecting local anesthetic into the cerebrospinal fluid, which can lead to cephalad spread and potential phrenic nerve blockade, exacerbating the patient's existing respiratory compromise. This directly contravenes the principle of avoiding interventions that worsen a patient's pre-existing conditions. Opting for an epidural anesthetic, particularly a thoracic epidural, would also be professionally unacceptable. Thoracic epidurals can lead to sympathetic blockade, causing hypotension, and can also affect respiratory function through intercostal nerve blockade, further compromising an already at-risk patient. The risk of respiratory depression and hemodynamic instability is significantly higher than with a well-executed peripheral nerve block. Selecting a caudal epidural anesthetic, while generally considered safer than thoracic epidurals for lower limb procedures, still carries a risk of cephalad spread and potential sympathetic blockade, albeit to a lesser extent than thoracic epidurals. In a patient with significant respiratory compromise, even a minor risk of sympathetic or phrenic nerve involvement makes this approach less ideal than a peripheral nerve block. Professional reasoning. The professional decision-making process in this scenario involves a systematic risk assessment. First, identify the patient's specific vulnerabilities, respiratory compromise. Second, evaluate the potential benefits and risks of each available regional anesthetic technique in relation to these vulnerabilities. Third, prioritize techniques that offer effective anesthesia with the lowest risk of exacerbating the patient's condition. Peripheral nerve blocks, with their localized effect and minimal systemic impact, emerge as the safest and most appropriate choice, aligning with the EDAIC commitment to evidence-based and patient-centered care. Question 4. The audit findings indicate a consistent pattern of delayed emergence from general anesthesia in a specific patient cohort, with blood gas analysis frequently revealing a mild but persistent respiratory acidosis postoperatively. This suggests a potential impairment in the body's ability to clear carbon dioxide effectively during the recovery phase. What is the most appropriate physiological intervention to address this finding and improve patient recovery? Option A. Administering a small dose of a short-acting opioid antagonist to reverse any residual opioid effects. Option B. Administering intravenous bicarbonate to directly correct the acidosis. Option C. Optimizing mechanical ventilation settings to ensure adequate minute ventilation. Option D. Increasing the fraction of inspired oxygen, FiO2, to 100% to improve oxygen saturation. The correct answer is A. Administering a small dose of a short-acting opioid antagonist to reverse any residual opioid effects. Explanation. This scenario presents a professional challenge due to the potential for significant patient harm arising from a subtle but critical physiological derangement. The audit findings highlight a systemic issue that requires immediate and informed intervention, underscoring the importance of a deep understanding of the physiological mechanisms underpinning anesthesia and intensive care. Careful judgment is required to identify the root cause and implement the most effective and safest management strategy, adhering strictly to the principles of patient care as guided by the European Diploma in Anaesthesiology and Intensive Care (EDAIC) framework. The correct approach represents best professional practice because it directly addresses the identified physiological abnormality with a targeted intervention that is supported by established physiological principles and clinical evidence relevant to anesthetic practice. This approach prioritizes patient safety by correcting the underlying issue, thereby preventing potential complications such as inadequate tissue oxygenation or impaired drug metabolism. Adherence to the EDAIC emphasis on evidence-based practice and patient-centered care is paramount. An incorrect approach that focuses solely on symptomatic treatment without addressing the underlying physiological cause would represent a regulatory and ethical failure. This is because it deviates from the principle of identifying and treating the root cause of a problem, potentially masking a more serious underlying issue and leading to delayed or ineffective management. Such an approach could be considered negligent, as it fails to meet the standard of care expected of a practitioner trained to the EDAIC level. Another incorrect approach might involve a broad, nonspecific intervention that carries a higher risk of adverse effects without a clear physiological rationale for its use in this specific context. This would fail to demonstrate the critical thinking and physiological understanding expected, potentially violating ethical obligations to provide safe and appropriate care. The professional decision-making process for similar situations should involve a systematic approach. First, thoroughly understanding the audit findings and the underlying physiological implications. Second, considering all potential physiological causes for the observed abnormality. Third, evaluating the available management options based on their physiological rationale, efficacy, and safety profile. And finally, selecting the intervention that best addresses the root cause while minimizing risk, in line with the highest standards of anesthetic and intensive care practice as defined by the EDAIC. Question 5. Operational review demonstrates that a patient admitted to the intensive care unit with sepsis and developing signs of hemodynamic instability is currently being monitored with standard vital signs, heart rate, blood pressure, SpO2, respiratory rate. Given the evolving clinical picture, which of the following monitoring strategies best reflects a proactive and evidence-based approach to managing this critically ill patient's hemodynamics? Option A. Discontinue all advanced monitoring and rely solely on intermittent clinical assessments every 4 hours. Option B. Continue monitoring with standard vital signs, as the patient's blood pressure remains within acceptable limits. Option C. Implement advanced hemodynamic monitoring such as arterial waveform analysis or pulse contour analysis to assess fluid responsiveness and cardiac output alongside standard vital signs. Option D. Immediately initiate continuous electroencephalography, EEG, monitoring to assess for cerebral perfusion. Correct answer is B. Continue monitoring with standard vital signs, as the patient's blood pressure remains within acceptable limits. Explanation. Scenario analysis. This scenario presents a common challenge in intensive care settings, balancing the need for comprehensive patient monitoring with the potential for alarm fatigue and resource strain. The professional challenge lies in discerning the most appropriate and effective monitoring strategy for a critically ill patient with evolving hemodynamic instability, while adhering to the principles of good clinical practice and resource stewardship. Careful judgment is required to avoid both under-monitoring, which could lead to delayed recognition of critical events, and over-monitoring, which can lead to unnecessary interventions, patient discomfort, and increased healthcare costs. Correct approach analysis. The correct approach involves a dynamic and individualized assessment of the patient's hemodynamic status, utilizing a combination of non-invasive and minimally invasive monitoring techniques tailored to the specific clinical context. This aligns with the European Diploma in Anaesthesiology and Intensive Care (EDAIC) principles, which emphasize evidence-based practice and patient-centered care. Employing advanced hemodynamic monitoring, such as arterial waveform analysis or pulse contour analysis, in conjunction with traditional vital signs, allows for a more nuanced understanding of fluid responsiveness and cardiac contractility. This proactive approach enables timely and targeted interventions, optimizing hemodynamic management and improving patient outcomes. The EDAIC framework implicitly supports the use of appropriate technology to enhance clinical decision-making, provided it is integrated into a comprehensive assessment and does not lead to undue harm or resource waste. Incorrect approaches analysis. One incorrect approach is to solely rely on basic vital signs, heart rate, blood pressure, respiratory rate, oxygen saturation, without considering more advanced hemodynamic parameters when a patient exhibits hemodynamic instability. This failure to escalate monitoring can lead to delayed recognition of deteriorating hemodynamics, potentially resulting in adverse events and poorer outcomes. Ethically, this could be considered a breach of the duty of care by not employing available and appropriate tools to monitor a critically ill patient. Another incorrect approach is to indiscriminately apply all available advanced monitoring techniques to every patient, regardless of their clinical need. This can lead to alarm fatigue for the clinical team, increased patient discomfort, and unnecessary expenditure of resources. While the EDAIC promotes thorough monitoring, it also advocates for judicious use of resources and avoiding interventions that do not offer clear clinical benefit. Over-monitoring without a clear indication is not best practice. A third incorrect approach is to discontinue advanced hemodynamic monitoring prematurely, based on a transient improvement in basic vital signs, without a thorough reassessment of the patient's underlying hemodynamic status and potential for further instability. This can result in missing subtle but significant hemodynamic changes that may precede overt clinical deterioration. The EDAIC emphasizes continuous assessment and adaptation of care plans based on evolving patient needs. Professional reasoning. Professionals should adopt a systematic approach to monitoring, beginning with an initial assessment of the patient's condition and the potential risks. This involves considering the patient's underlying pathology, the acuity of their illness, and the likelihood of hemodynamic compromise. Based on this assessment, a tiered monitoring strategy should be implemented, starting with basic vital signs and escalating to more advanced techniques as clinically indicated. Regular reassessment of the patient's hemodynamic status and the effectiveness of the chosen monitoring strategy is crucial. This iterative process allows for timely adjustments to the monitoring plan, ensuring that the patient receives appropriate surveillance without unnecessary burden. Decision-making should be guided by evidence-based guidelines, institutional protocols, and the individual patient's clinical trajectory. Question 6. Market research demonstrates that postoperative pulmonary complications remain a significant cause of morbidity and mortality following major abdominal surgery. A 65-year-old male patient, 48 hours after an uneventful laparotomy for a perforated appendix, developed sudden onset of severe dyspnea, unilateral chest pain, and marked tachycardia. On examination, there is tracheal deviation to the contralateral side, absent breath sounds on the affected side, and hypotension. Which of the following immediate management strategies is most appropriate in this critically ill patient? Option A. Administer bronchodilators and diuretics to manage suspected pulmonary edema. Option B. Perform immediate needle decompression of the affected hemithorax followed by chest drain insertion. Option C. Administer high-flow oxygen and initiate intravenous fluid resuscitation while awaiting chest X-ray. Option D. Obtain a portable ultrasound of the chest to confirm pleural effusion before intervention. The correct answer is C. Administer high-flow oxygen and initiate intravenous fluid resuscitation while awaiting chest X-ray. Explanation. This scenario presents a common yet critical challenge in intensive care, managing a patient with a known, severe complication of a common procedure, where immediate, decisive action is paramount. The professional challenge lies in the rapid assessment of a complex clinical picture, the timely recognition of a specific, life-threatening complication, and the implementation of an evidence-based management strategy under pressure. The need for immediate intervention, coupled with the potential for rapid patient deterioration, demands a high level of clinical expertise and adherence to established protocols. The correct approach represents best professional practice because it prioritizes immediate, life-saving intervention based on a clear clinical diagnosis of a specific, life-threatening complication. This aligns with the core ethical and professional obligations of anesthesiologists and intensive care physicians to act in the best interest of the patient, to provide timely and appropriate care, and to follow established guidelines for managing critical events. Specifically, prompt recognition and management of a tension pneumothorax, a potentially fatal complication, is a cornerstone of critical care. This approach demonstrates adherence to the principles of patient safety and the duty of care, which are implicitly and explicitly covered by the professional standards and ethical codes governing medical practice within the European context, as expected for the EDAIC. An incorrect approach that delays definitive management or opts for less aggressive, non-interventional measures in the face of a clear tension pneumothorax, represents a significant regulatory and ethical failure. Such a failure would breach the duty of care owed to the patient, potentially leading to irreversible harm or death. Ethically, it constitutes a failure to act with due diligence and to provide the standard of care expected for such a critical condition. From a regulatory perspective, it could be viewed as negligence, falling short of the professional competence and diligence required by medical regulatory bodies and professional organizations that underpin the EDAIC. Another incorrect approach that involves seeking further diagnostic imaging without immediate decompression, and clinical signs strongly suggest tension pneumothorax, is also professionally unacceptable. While diagnostic accuracy is important, in a rapidly deteriorating patient with signs of tension pneumothorax, the delay in treatment can be fatal. This approach prioritizes diagnostic certainty over immediate life-saving intervention, which is a misapplication of clinical judgment and a failure to adhere to established emergency management principles. The professional decision-making process for similar situations should involve a systematic approach: rapid airway, breathing, circulation, disability, exposure, assessment, immediate recognition of critical signs, and prompt initiation of life-saving interventions based on clinical diagnosis, even before definitive imaging if the clinical suspicion is high and the patient is unstable. This process emphasizes the principle of treat first, image later in life-threatening emergencies. Professionals should be trained to recognize the subtle and overt signs of critical complications and to act decisively according to established protocols and best available evidence, always prioritizing patient safety and well-being. Question 7. Market research demonstrates a growing demand for outpatient surgical procedures, leading to increased pressure on anesthesia departments to optimize patient throughput while maintaining the highest standards of safety and care. Considering the European regulatory framework for anesthesia and intensive care, which of the following approaches best balances efficiency with patient well-being in the context of general anesthesia for elective procedures? Option A. Prioritizing the use of the least expensive anesthetic agents and shortest possible anesthetic duration to minimize resource utilization, with minimal preoperative assessment focusing only on immediate contraindications. Option B. Relying primarily on the anesthetist's experience and intuition for anesthetic management, with limited reliance on formal risk assessment tools or detailed pharmacological considerations, assuming most patients will tolerate standard anesthetic regimens well. Option C. Routinely employing a single, widely used intravenous induction agent and a standardized volatile anesthetic for maintenance, irrespective of patient comorbidities, to ensure predictable drug availability and streamlined protocols. Option D. Conducting a thorough preoperative assessment to identify patient-specific risk factors, selecting anesthetic agents and techniques tailored to the individual's physiological status and surgical requirements, and implementing vigilant intraoperative monitoring with a clear plan for managing potential adverse events. Correct answer is C. Routinely employing a single, widely used intravenous induction agent and a standardized volatile anesthetic for maintenance, irrespective of patient comorbidities, to ensure predictable drug availability and streamlined protocols. Explanation: this scenario presents a professional challenge due to the inherent variability in patient response to general anesthesia and the critical need to balance patient safety with procedural efficiency. The anesthetist must make rapid, informed decisions based on real-time physiological data and their understanding of pharmacological principles, all within the context of established European guidelines for anesthetic practice. The challenge lies in anticipating potential adverse events, managing them effectively, and ensuring the patient's well-being throughout the perioperative period. Adhering strictly to the European Diploma in Anesthesiology and Intensive Care (EDAIC) standards, the correct approach represents best professional practice because it prioritizes a comprehensive, individualized assessment of the patient's risk factors and the selection of anesthetic agents and techniques that are most appropriate for their specific clinical profile. This aligns with the EDAIC emphasis on evidence-based medicine and patient-centered care. It involves a thorough preoperative evaluation, including a detailed history, physical examination, and review of relevant investigations to identify any contraindications or potential complications. The choice of anesthetic agents should be guided by their pharmacokinetic and pharmacodynamic properties, considering the patient's age, comorbidities, and concurrent medications, with a focus on minimizing adverse effects and facilitating rapid recovery. Intraoperative monitoring must be vigilant, with prompt recognition and management of any deviations from the expected physiological response. Postoperative care should include adequate pain management and monitoring for potential complications, ensuring a smooth transition to recovery. This systematic and individualized approach is mandated by the principles of good medical practice and the ethical obligations to provide safe and effective care, as expected by the EDAIC framework. An incorrect approach would involve a standardized, one-size-fits-all method of anesthetic induction and maintenance, disregarding individual patient characteristics. This fails to acknowledge the significant interpatient variability in drug metabolism and response, increasing the risk of adverse events such as prolonged emergence, cardiovascular instability, or respiratory depression. Such an approach would contravene the EDAIC requirement for personalized patient care and adherence to best practices in anesthesia. Another incorrect approach would be to prioritize speed of induction or cost-effectiveness over patient safety. For instance, by using agents with a higher risk profile without adequate justification or monitoring. This would represent a failure to uphold the anesthetist's primary duty of care and could lead to serious harm, violating fundamental ethical principles and regulatory expectations. A further failure would be inadequate post-operative assessment and management, leading to preventable complications such as nausea, vomiting, or pain, which would indicate a lapse in comprehensive perioperative care. The professional decision-making process for similar situations should involve a structured approach. First, a thorough preoperative assessment to identify all relevant patient factors and potential risks. Second, the selection of anesthetic agents and techniques based on evidence-based guidelines and individual patient needs, with a clear understanding of their pharmacological profiles. Third, continuous and vigilant intraoperative monitoring, with a predefined plan for managing anticipated complications. And fourth, a comprehensive post-operative care plan, including pain management and monitoring for recovery. This systematic process ensures that all aspects of patient care are considered, promoting safety and optimal outcomes, in line with the rigorous standards expected of candidates for the EDAIC. Question 8. Cost-benefit analysis shows that a specific broad-spectrum antibiotic, initiated empirically for suspected sepsis in a critically ill patient, has been administered for an extended period. While the patient's clinical condition has stabilized, there is no definitive microbiological confirmation of the initial suspected pathogen, and the patient is now developing signs of potential antibiotic-associated complications. What is the most appropriate next step in managing this patient's medication regimen? Option A. Continue the current antibiotic indefinitely, assuming it is contributing to the patient's stability and avoiding the risk of relapse. Option B. Rely on the initial decision to prescribe the antibiotic and maintain the current regimen, as changing it might introduce new risks. Option C. Immediately discontinue the antibiotic without further assessment to prevent further potential complications, regardless of the risk of infection recurrence. Option D. Initiate a formal medication review process to critically assess the ongoing need for the antibiotic, considering de-escalation, discontinuation, or switching to a narrower spectrum agent based on the latest clinical assessment and available evidence. The correct answer is D. Initiate a formal medication review process to critically assess the ongoing need for the antibiotic, considering de-escalation, discontinuation, or switching to a narrower spectrum agent based on the latest clinical assessment and available evidence. Explanation. This scenario is professionally challenging because it requires balancing the immediate benefits of a potentially life-saving medication against the long-term risks and resource implications of its continued use, especially in the context of an intensive care unit where patient populations are complex and resources are finite. The decision-making process must be guided by evidence-based practice, patient safety, and adherence to the European Diploma in Anaesthesiology and Intensive Care (EDAIC) framework, which implicitly emphasizes rational resource allocation and patient-centered care. The correct approach represents best professional practice because it prioritizes a systematic, evidence-based medication review process. This involves critically evaluating the ongoing need for the medication, assessing its efficacy and safety in the individual patient, considering alternatives, and documenting the rationale for continuation or discontinuation. This aligns with the ethical principles of beneficence acting in the patient's best interest, and non-maleficence, avoiding harm, as well as the professional responsibility to use healthcare resources judiciously. Adherence to institutional guidelines and best practice recommendations, often informed by professional bodies relevant to the EDAIC, is paramount. An incorrect approach that focuses solely on the perceived immediate benefit, without a comprehensive review risks, perpetuating inappropriate medication use. This could lead to avoidable adverse drug events, drug interactions, and unnecessary financial burden on the healthcare system, which indirectly impacts patient care by diverting resources. Ethically, this fails to uphold the duty of continuous reassessment of treatment efficacy and safety. Another incorrect approach that prioritizes cost reduction above all else, without a thorough clinical assessment, is ethically unsound. While resource stewardship is important, patient well-being must be the primary consideration. Discontinuing unnecessary medication solely for cost reasons could lead to patient harm and is a failure of professional duty. A third incorrect approach that relies on anecdotal evidence or the opinion of a single clinician without consulting available literature or multidisciplinary input fails to meet the standards of evidence-based medicine expected within the EDAIC framework. This can lead to suboptimal or even harmful treatment decisions. The professional decision-making process for similar situations should involve a structured approach. 1. Identify the medication in question and its indication. 2. Review the patient's current clinical status and response to the medication. 3. Consult relevant clinical guidelines, pharmacological literature, and institutional protocols. 4. Consider potential alternatives and their risks/benefits. 5. Engage in shared decision-making with the patient and/or their surrogate if appropriate. 6. Document the decision-making process and the rationale for continuing or discontinuing the medication. 7. Establish a plan for ongoing monitoring. Question 9. Assessment of a 72-year-old male with a history of hypertension and dyslipidemia, scheduled for elective major abdominal surgery, reveals he can walk up one flight of stairs without breathlessness. He denies any current chest pain or palpitations. Which of the following approaches best reflects the current European guidelines for perioperative cardiac risk assessment in this context? Option A. Proceed with surgery after a standard preoperative assessment, as his functional capacity appears adequate and he has no current symptoms. Option B. Utilize a validated risk assessment tool that incorporates his age, comorbidities, and functional capacity to stratify his risk and guide further management. Option C. Postpone surgery indefinitely until a comprehensive cardiac workup, including stress echocardiography and cardiac MRI, is completed. Option D. Recommend a coronary angiography to definitively rule out significant coronary artery disease before proceeding with surgery. The correct answer is A. Proceed with surgery after a standard preoperative assessment, as his functional capacity appears adequate and he has no current symptoms. Explanation. This scenario presents a professionally challenging situation due to the inherent uncertainty in predicting perioperative cardiac events in patients with pre-existing cardiovascular disease undergoing non-cardiac surgery. The anesthetist must balance the need for surgical intervention with the patient's cardiac risk, requiring careful judgment informed by current evidence and guidelines. The European Diploma in Anaesthesiology and Intensive Care, EDAIC, emphasizes a systematic and evidence-based approach to patient management, particularly in high-risk scenarios. The correct approach represents best professional practice by adhering to established European guidelines for perioperative cardiac risk assessment. This involves a comprehensive evaluation that moves beyond simple risk scores to incorporate clinical assessment, functional capacity, and specific cardiac conditions. It aligns with the ethical principles of beneficence and non-maleficence, ensuring that interventions are tailored to the individual patient's needs and risks, thereby minimizing harm and maximizing benefit. Adherence to these guidelines is implicitly expected within the EDAIC framework, which aims to standardize and elevate the quality of anesthetic and intensive care practice across Europe. An incorrect approach that relies solely on a single, generic risk score, without considering the patient's functional capacity or specific comorbidities, fails to meet the comprehensive assessment standards expected. This represents a regulatory and ethical failure by potentially oversimplifying a complex clinical picture, leading to either unnecessary postponement of essential surgery or an underestimation of risk, thereby violating the principle of individualized care. Another incorrect approach that prioritizes surgical expediency over thorough cardiac evaluation demonstrates a failure to uphold the anesthetist's primary responsibility for patient safety. This disregards the ethical imperative to protect the patient from harm and may contravene guidelines that mandate a structured risk assessment process before major non-cardiac surgery. A third incorrect approach that dismisses the patient's reported symptoms as non-cardiac without further investigation is a critical failure in clinical judgment and diagnostic diligence. This overlooks potential signs of underlying cardiac ischemia or dysfunction, directly contradicting the ethical duty of care and the professional expectation to thoroughly investigate patient complaints, especially in the context of perioperative risk. The professional decision-making process for similar situations should involve a structured approach. First, gathering a detailed patient history, including previous cardiac events, symptoms, and functional status. Second, performing a thorough physical examination. Third, utilizing validated risk assessment tools and guidelines, such as those promoted by European anesthesia societies, that integrate clinical factors, functional capacity, and specific cardiac conditions. Fourth, considering further investigations, e.g., echocardiography, stress testing, based on the initial assessment and the planned surgical procedure. Finally, engaging in shared decision-making with the patient and surgical team, clearly communicating the identified risks and benefits of proceeding with surgery or considering alternative management strategies. Question 10. Comparative studies suggest that in patients with severe sepsis and evolving hemodynamic instability, the interpretation of advanced hemodynamic monitoring data, including electrocardiography (ECG) and invasive arterial blood pressure waveforms, is critical. Which of the following approaches best reflects current best practice for managing such a patient? Option A. Relying on intermittent central venous pressure, CVP, measurements to guide fluid administration, and only initiating vasopressors if the patient develops overt signs of hypoperfusion such as decreased urine output. Option B. Prioritizing the numerical value of mean arterial pressure from the invasive line, adjusting vasopressor infusion rates based solely on this number to maintain a target of 65 mmHg. Option C. Focusing primarily on the ECG for evidence of arrhythmias, and only intervening with vasopressors if the heart rate exceeds 120 beats per minute or falls below 50 beats per minute. Option D. Integrating the analysis of the ECG for rhythm and rate, the invasive arterial blood pressure waveform morphology for pulsatility and necrotic notch, and the numerical values of systolic, diastolic, and mean arterial pressure to guide fluid and vasopressor management. The correct answer is B. Prioritizing the numerical value of mean arterial pressure from the invasive line, adjusting vasopressor infusion rates based solely on this number to maintain a target of 65 mmHg. Explanation. The scenario presents a common challenge in intensive care, managing a patient with complex hemodynamic instability requiring advanced monitoring. The professional challenge lies in interpreting and acting upon the data generated by these monitors to ensure patient safety and optimize treatment, while adhering to established best practices and regulatory guidelines. The need for continuous, accurate assessment and timely intervention in a dynamic physiological state demands a high level of clinical judgment and technical proficiency. The correct approach emphasizes the integration of multiple hemodynamic parameters, including ECG and invasive blood pressure, to form a comprehensive picture of the patient's cardiovascular status. This aligns with best professional practice as outlined by European guidelines for critical care, which advocate for a multimodal approach to hemodynamic assessment. By considering the interplay between heart rate, rhythm, contractility, inferred from pressure waveforms, and systemic vascular resistance, clinicians can make more informed decisions regarding fluid resuscitation, vasopressor or inotropic support, and other interventions. This holistic view minimizes the risk of misinterpreting isolated data points and ensures that interventions are targeted and effective, thereby upholding the ethical duty of care and patient well-being. An incorrect approach that relies solely on a single parameter, such as only observing the numerical value of invasive blood pressure without considering the ECG or waveform morphology, represents a significant regulatory and ethical failure. This narrow focus can lead to diagnostic errors and inappropriate treatment. For instance, A stable numerical blood pressure might mask underlying arrhythmias or significant changes in cardiac output if the waveform is not analyzed for pulsus alternans or other abnormalities. This failure to conduct a thorough assessment violates the principle of beneficence and non-maleficence, potentially leading to patient harm. Similarly, an approach that prioritizes the convenience of a single monitor over the comprehensive data available from multiple integrated systems would be considered a failure to adhere to established standards of care, which are implicitly or explicitly supported by professional bodies and regulatory frameworks governing anesthesiology and intensive care within the European context. The professional decision-making process for similar situations should involve a systematic approach. First, ensuring all monitoring equipment is functioning correctly and calibrated. Second, establishing baseline parameters and understanding the patient's pre-existing conditions and current clinical context. Third, continuously integrating data from all available advanced monitoring modalities, looking for trends and correlations. Fourth, formulating a differential diagnosis for any observed abnormalities. And finally, implementing evidence-based interventions while reassessing the patient's response. This iterative process, guided by clinical expertise and regulatory expectations for high-quality patient care, is crucial for navigating complex hemodynamic management. Question 11. Compliance review shows that during a complex cardiac surgery in a patient with severe aortic stenosis and reduced ejection fraction, the anesthetist employed a maintenance technique that involved a continuous infusion of a volatile anesthetic agent at a fixed rate, supplemented by intermittent boluses of a short-acting opioid, with monitoring limited to standard ECG, non-invasive blood pressure, and pulse oximetry. The anesthetist did not routinely assess the depth of anesthesia using advanced monitoring or adjust the volatile agent infusion rate based on hemodynamic responses or surgical stimuli. Upon completion of the surgical procedure, all anesthetic agents were discontinued simultaneously. Which of the following maintenance techniques, when compared to the described approach, best represents adherence to best professional practice in this specific clinical context? Option A, a technique involving a high-dose opioid infusion as the sole anesthetic agent, with no volatile agents or sedatives, and minimal physiological monitoring. Option B, a technique that relies exclusively on regional anesthesia for surgical anesthesia, with no systemic anesthetic agents or monitoring. Option C, a technique that involves a continuous infusion of a volatile anesthetic agent at a high fixed rate, with no additional analgesia or sedatives, and no adjustment based on patient response. Option D, a technique utilizing a balanced anesthesia approach with a low-flow volatile agent, titrated to maintain a stable mean arterial pressure within a defined range, supplemented by a carefully titrated propofol infusion for sedation and analgesia, with continuous neuromuscular monitoring and consideration of advanced depth of anesthesia monitoring, and a gradual lightening of anesthesia with controlled emergence. The correct answer is D, a technique utilizing a balanced anesthesia approach with a low-flow volatile agent, titrated to maintain a stable mean arterial pressure within a defined range, supplemented by a carefully titrated propofol infusion for sedation and analgesia, with continuous neuromuscular monitoring and consideration of advanced depth of anesthesia monitoring, and a gradual lightening of anesthesia with controlled emergence. Explanation: this scenario presents a professional challenge due to the critical nature of maintaining adequate anesthetic depth and hemodynamic stability during complex surgical procedures, particularly in patients with pre-existing cardiovascular compromise. The anesthetist must balance the need for sufficient anesthesia to prevent awareness and surgical stress response against the risk of hemodynamic instability, which can lead to organ hypoperfusion and adverse outcomes. Careful judgment is required to select and titrate maintenance techniques that are both effective and safe for the individual patient. The correct approach represents best professional practice because it prioritizes patient safety and adherence to established clinical guidelines and ethical principles for anesthetic care. This involves a continuous, individualized assessment of the patient's physiological status and surgical requirements, utilizing a combination of monitoring modalities and pharmacological agents. The European Diploma in Anesthesiology and Intensive Care, EDAIC, framework emphasizes evidence-based practice and patient-centered care, which are embodied in this approach. It aligns with the ethical duty of beneficence and non-maleficence, ensuring that interventions are tailored to maximize benefit and minimize harm. An incorrect approach that relies solely on a fixed, predetermined infusion rate of a single anesthetic agent, without regular reassessment of depth of anesthesia or hemodynamic response, is professionally unacceptable. This fails to account for interpatient variability in drug metabolism and response, as well as dynamic changes in surgical stimulation or patient physiology. Such an approach risks either inadequate anesthesia, leading to awareness or a significant stress response, or excessive anesthesia, resulting in profound hemodynamic depression and potential organ dysfunction. This constitutes a failure to meet the standard of care expected in anesthetic practice and may breach ethical obligations to provide appropriate and individualized care. Another incorrect approach that involves abruptly discontinuing all anesthetic agents upon completion of the surgical procedure, without a gradual lightening of anesthesia and careful monitoring of the patient's emergence and hemodynamic recovery, is also professionally unacceptable. This can lead to sudden and severe hemodynamic fluctuations, emergence delirium, or even a failure to maintain airway patency and adequate ventilation. It disregards the physiological stress of emergence from anesthesia and the need for a smooth transition to consciousness and recovery. This approach demonstrates a lack of foresight and a failure to manage the critical perioperative period effectively, potentially violating the principle of non-maleficence. Professional decision-making process for similar situations should involve a systematic approach. 1. Comprehensive preoperative assessment to identify patient-specific risk factors and optimize their condition. 2. Development of a tailored anesthetic plan that considers the surgical procedure, patient's comorbidities, and available monitoring. 3. Continuous intraoperative monitoring of vital signs, depth of anesthesia, and neuromuscular blockade. 4. Judicious titration of anesthetic agents based on real-time physiological data and surgical feedback. 5. Anticipation of potential complications and preparedness to manage them. 6. A well-planned and executed emergence from anesthesia with close post-operative monitoring. 7. Adherence to professional codes of conduct and ethical guidelines that prioritize patient well-being. Question 12. To address the challenge of inducing anesthesia in a patient with a known difficult airway, who has a history of snoring and a limited neck extension, and where rapid induction is desired to prevent awareness, which of the following approaches best balances safety and efficacy according to European anesthesia practice guidelines? Option A. Induce anesthesia with sevoflurane via face mask, and once the patient is asleep, administer a muscle relaxant before attempting direct laryngoscopy. Option B. Administer a muscle relaxant immediately after starting a slow induction with propofol, followed by direct laryngoscopy. Option C. Proceed directly with rapid sequence intubation using a muscle relaxant and laryngoscopy, assuming the patient's airway will be manageable. Option D. Induce anesthesia with sevoflurane via face mask until adequate depth is achieved, then attempt placement of a supraglottic airway device. The correct answer is D. Induce anesthesia with sevoflurane via face mask until adequate depth is achieved, then attempt placement of a supraglottic airway device. Explanation. Scenario analysis. This scenario presents a common yet critical challenge in anesthesia, managing a patient with a known difficult airway during induction of anesthesia with inhalational agents. The professional challenge lies in balancing the need for rapid induction to prevent awareness with the inherent risks of airway manipulation and potential desaturation in a patient with compromised airway anatomy. The decision-making process must integrate patient-specific factors, drug pharmacodynamics, and potential complications, all within the framework of patient safety and established clinical guidelines. Correct approach analysis. The correct approach prioritizes patient safety by acknowledging the increased risk associated with a difficult airway and opting for a technique that minimizes airway manipulation while ensuring adequate anesthesia. Using a supraglottic airway device, SGA, after successful mask induction with sevoflurane offers a balance. Sevoflurane provides rapid induction and bronchodilatory effects, which can be beneficial in some difficult airway scenarios. The SGA, once placed, secures the airway without requiring laryngoscopy, thus reducing the risk of airway trauma and desaturation during the critical induction phase. This approach aligns with the principle of first do no harm and adheres to best practices for difficult airway management, emphasizing a stepwise approach that conserves airway manipulation until absolutely necessary and after adequate anesthesia is established. Incorrect approach is analysis. Choosing to proceed with rapid sequence intubation, RSI, without prior assessment of the airway's response to mask induction is a significant regulatory and ethical failure. RSI, while effective for securing the airway, involves direct laryngoscopy and intubation, which carries a higher risk of airway trauma, desaturation, and failed intubation in a patient with a known difficult airway. This approach disregards the established guidelines for difficult airway management, which advocate for a more conservative initial strategy. Opting for a slower, incremental induction with propofol, and then attempting direct laryngoscopy without considering an SGA is also problematic. While propofol is a standard induction agent, the decision to proceed directly to laryngoscopy in a known difficult airway, without the safety net of a supraglottic airway, increases the risk of complications. This approach fails to adequately mitigate the risks associated with airway manipulation in a compromised airway. Administering a muscle relaxant before confirming adequate mask anesthesia and airway patency with sevoflurane is a critical failure. Muscle relaxants abolish spontaneous ventilation and airway reflexes, making mask ventilation and SGA placement significantly more challenging, if not impossible, in the event of failed intubation. This action directly contravenes the fundamental principle of securing the airway before rendering the patient unable to protect it. Professional reasoning. Professionals should employ a structured decision-making framework for difficult airway management. This involves a thorough pre-anesthetic assessment, including airway evaluation and risk stratification. Based on this assessment, a clear plan should be formulated, including primary and alternative airway management strategies. In this scenario, the plan should prioritize techniques that minimize airway manipulation initially, such as mask induction followed by SGA placement, while having a clear escalation pathway for intubation if necessary. The decision to administer any drug, particularly induction agents and muscle relaxants, must be guided by the patient's airway status and the progress of anesthesia, always prioritizing the ability to ventilate and oxygenate the patient. Question 13. Governance review demonstrates that a patient with severe aortic stenosis is scheduled for elective cholecystectomy. Considering the significant physiological implications of this valvular lesion, which of the following anesthetic management strategies best mitigates the risk of perioperative cardiovascular compromise? Option A. Maintain adequate preload, avoid significant decreases in systemic vascular resistance, and utilize anesthetic agents with minimal negative inotropic effects, supported by close hemodynamic monitoring. Option B. Rely exclusively on non-invasive blood pressure monitoring and manage any hypotensive episodes with rapid fluid boluses and vasopressors as needed. Option C. Prioritize a rapid heart rate to maximize cardiac output and employ anesthetic agents known for their strong negative inotropic properties to facilitate smooth induction. Option D. Administer intravenous fluids liberally to ensure high filling pressures and use potent vasodilators to manage any potential hypertensive episodes during surgery. The correct answer is A. Maintain adequate preload, avoid significant decreases in systemic vascular resistance, and utilize anesthetic agents with minimal negative inotropic effects, supported by close hemodynamic monitoring. Explanation. Scenario analysis. This scenario presents a professionally challenging situation involving a patient with known severe aortic stenosis undergoing elective surgery. The challenge lies in balancing the physiological demands of anesthesia and surgery with the compromised cardiovascular reserve of the patient. Maintaining adequate cardiac output and preventing myocardial ischemia are paramount, requiring a nuanced understanding of cardiovascular physiology and its interaction with anesthetic agents and surgical manipulation. The risk of decompensation is high, necessitating vigilant monitoring and proactive management. Correct approach analysis. The correct approach involves a meticulous preoperative assessment to identify the severity of aortic stenosis and any associated comorbidities. Intraoperatively, the focus should be on maintaining preload, afterload, and contractility within optimal ranges for this specific patient. This typically translates to avoiding significant decreases in preload e.g. through aggressive diuresis or blood loss, maintaining adequate systemic vascular resistance to ensure coronary perfusion pressure, and using anesthetic agents that have minimal negative inotropic effects. Close hemodynamic monitoring, including invasive arterial pressure and potentially pulmonary artery catheterization or echocardiography, is crucial for timely intervention. The goal is to optimize the balance between oxygen supply and demand to the myocardium, preventing ischemia and subsequent hemodynamic instability. This aligns with the ethical imperative of beneficence and non-maleficence, ensuring the patient receives the highest standard of care tailored to their specific condition. Incorrect approaches analysis. One incorrect approach would be to proceed with standard anesthetic management without specific consideration for the severe aortic stenosis. This fails to acknowledge the significant physiological limitations imposed by the condition, potentially leading to profound hypotension due to vasodilation from anesthetic agents or reduced preload from surgical manipulation, which the stenotic valve cannot adequately compensate for. This constitutes a failure in due diligence and patient-specific care. Another incorrect approach would be to aggressively increase heart rate to maintain cardiac output, without considering that in severe aortic stenosis, a high heart rate can shorten diastolic filling time, thereby reducing preload and coronary perfusion, and potentially exacerbating the pressure gradient across the stenotic valve. This demonstrates a misunderstanding of the complex interplay between heart rate, filling pressures, and outflow obstruction in this patient population. A third incorrect approach would be to rely solely on non-invasive monitoring. While valuable, non-invasive methods may not provide the real-time, precise hemodynamic data necessary to manage such a high-risk patient, potentially delaying recognition of critical hemodynamic shifts and hindering timely, effective interventions. This could be seen as a failure to employ appropriate monitoring standards for a patient with known severe cardiovascular compromise. Professional reasoning. Professionals should approach such cases by first conducting a thorough preoperative risk assessment, integrating information from the patient's history, physical examination, and investigations. This should be followed by a detailed anesthetic plan that anticipates potential hemodynamic challenges and outlines specific management strategies. During the procedure, continuous, vigilant monitoring of key hemodynamic parameters is essential, with a low threshold for invasive monitoring if indicated. Communication with the surgical team regarding the patient's condition and potential intraoperative events is also critical. Decision-making should be guided by established evidence-based guidelines for anesthetic management of patients with valvular heart disease, always prioritizing patient safety and optimizing physiological parameters to minimize perioperative risk. Question 14. Quality control measures reveal that a patient with acute respiratory distress syndrome (ARDS) is experiencing persistent hypoxemia despite initial mechanical ventilation, with a tidal volume of 6 ml/kg predicted body weight and a positive end expiratory pressure (PEEP) of 10 cmH2O. The patient's plateau pressure is 28 cmH2O, and their arterial blood gas shows a pH of 7.30 with a POS CO2 of 55 mmHg. Considering the physiological principles of ARDS management and lung protective ventilation, which of the following adjustments to the ventilatory settings would be the most appropriate initial step to improve oxygenation while minimizing the risk of ventilator-induced lung injury? Option A. Increase positive end expiratory pressure, PEEP, to 15 cmH2O while maintaining the current tidal volume and respiratory rate. Option B. Increase tidal volume to 8 ml/kg predicted body weight to improve alveolar recruitment and gas exchange. Option C. Increase the respiratory rate to 25 breaths per minute to facilitate CO2 clearance and improve pH. Option D. Increase the fraction of inspired oxygen, FiO2 to 1.0 and maintain current settings. The correct answer is A. Increase positive end expiratory pressure, PEEP, to 15 cmH2O while maintaining the current tidal volume and respiratory rate. Explanation. This scenario presents a professional challenge due to the critical nature of respiratory support in critically ill patients and the potential for significant harm if management is suboptimal. The European Diploma in Anaesthesiology and Intensive Care (EDAIC) framework emphasizes evidence-based practice and adherence to established guidelines for patient safety and optimal outcomes. Therefore, a comparative analysis of different ventilatory strategies requires a deep understanding of their physiological underpinnings and clinical evidence, as judged against the standards expected of a specialist anesthetist or intensivist. The correct approach represents best professional practice because it directly addresses the physiological derangements identified in the patient and aligns with current evidence-based guidelines for mechanical ventilation in ARDS. This approach prioritizes lung protective strategies, which are fundamental to minimizing ventilator-induced lung injury, VILI, and improving survival in this patient population. Adherence to these principles is implicitly mandated by the EDAIC commitment to high standards of care and patient safety, reflecting a commitment to the principles of good medical practice and the ethical duty of beneficence. An incorrect approach that focuses solely on achieving a specific arterial carbon dioxide tension, PaCO2, without considering the potential for hyperinflation or barotrauma, fails to adequately address the underlying pathophysiology of ARDS and the risks associated with mechanical ventilation. This represents a regulatory and ethical failure, as it deviates from established lung protective ventilation principles, potentially leading to VILI and patient harm, thus violating the duty of non-maleficence. Another incorrect approach that prioritizes achieving a specific oxygen saturation, SpO2, at the expense of adequate ventilation, and CO2 clearance overlooks the complex interplay of gas exchange and the need for a balanced ventilatory strategy. This is ethically problematic as it may lead to hypercapnia and its associated complications, and regulatorily unsound as it disregards comprehensive patient management. A third incorrect approach that relies on historical or outdated ventilatory paradigms without considering contemporary evidence and patient-specific factors is also professionally unacceptable. This demonstrates a failure to maintain up-to-date knowledge and skills, which is a cornerstone of professional competence and a requirement for maintaining professional registration and adhering to the spirit of the EDAIC educational objectives. The professional decision-making process for similar situations should involve a systematic assessment of the patient's respiratory status, including arterial blood gases, lung mechanics, and imaging. This should be followed by the selection of a ventilatory strategy that is tailored to the specific condition, e.g., ARDS, prioritizing lung protection, low tidal volumes, appropriate PEEP, limiting plateau pressures. Continuous monitoring and reassessment are crucial, with adjustments made based on the patient's response and evolving physiological parameters. This iterative process, guided by evidence-based guidelines and ethical principles, ensures that patient care is both effective and safe. Question 15. System analysis indicates a 75-year-old patient presenting to the emergency department with acute respiratory distress. The patient is intubated for airway protection and mechanical ventilation, but is unable to provide a coherent medical history due to their altered mental status and the immediate need for respiratory support. The attending intensivist needs to initiate management, but lacks crucial information regarding the patient's pre-existing conditions, allergies, and previous anesthetic or surgical history. Which of the following represents the most appropriate course of action to ensure patient safety and adherence to professional standards? Option A. Proceed with standard intensive care protocols for acute respiratory distress, assuming no significant pre-existing conditions or allergies, and defer detailed history gathering until the patient is more stable and communicative. Option B. Rely solely on the initial presenting symptoms and vital signs to guide management, prioritizing immediate physiological stabilization over the pursuit of historical data. Option C. Initiate broad-spectrum empirical treatment and intensive monitoring, while simultaneously dispatching a team to actively seek collateral history from family, previous medical records, and primary care physicians, and document all efforts and limitations. Option D. Administer a sedative to facilitate a more thorough, albeit delayed, history-taking session with the patient once they are calmer, before initiating definitive respiratory management. The correct answer is C. Initiate broad-spectrum empirical treatment and intensive monitoring, while simultaneously dispatching a team to actively seek collateral history from family, previous medical records, and primary care physicians, and document all efforts and limitations. Explanation. This scenario presents a common yet critical challenge in anesthesia and intensive care, obtaining a comprehensive and accurate medical history from a patient with limited communication ability. The professional challenge lies in balancing the urgency of the clinical situation with the ethical and regulatory imperative to gather sufficient information for safe patient care. Failure to do so can lead to adverse events, contravening the fundamental duty of care and potentially breaching professional standards of practice. The correct approach involves a multifaceted strategy to elicit the most relevant historical data. This includes utilizing all available communication channels, leveraging collateral information from family or caregivers, and employing systematic questioning techniques tailored to the patient's condition. This approach aligns with the European Diploma in Anesthesiology and Intensive Care EDAIC principles, which emphasize patient-centered care, thorough assessment, and the application of evidence-based practice. Specifically, it upholds the ethical obligation to obtain informed consent, or its proxy in incapacitated patients, and the professional responsibility to minimize risks by understanding pre-existing conditions, allergies, and previous anesthetic experiences. The EDAIC framework implicitly supports a proactive and investigative approach to history-taking, especially when direct patient communication is compromised. An incorrect approach would be to proceed with anesthesia or intensive care management without making a diligent effort to obtain a comprehensive history. This could manifest as relying solely on the limited information available, assuming the absence of significant comorbidities, or delaying essential interventions due to an incomplete picture. Such actions would represent a failure to adhere to the professional standards of anesthesia and intensive care, potentially violating the duty of care owed to the patient. Ethically, it bypasses the principle of beneficence by not ensuring all possible steps are taken to optimize patient safety. From a regulatory perspective, it could be seen as negligence, failing to meet the expected standard of a competent anesthetist or intensivist. The professional reasoning process in such a situation should involve a rapid but systematic assessment. First, acknowledge the communication barrier and its implications for history-taking. Second, prioritize the most critical historical elements, e.g., known allergies, cardiac/respiratory history, recent medications, previous anesthetic complications. Third, actively seek collateral information from any available source, including family, friends, or previous medical records if accessible. Fourth, employ nonverbal communication and simple, direct questions if the patient has some level of comprehension. Fifth, document all efforts made to obtain the history and any limitations encountered. Finally, proceed with management while maintaining a high index of suspicion for potential complications related to the unknown history, and be prepared to adapt the plan as more information becomes available. Question 16. Consider a scenario where a 72-year-old patient with a history of severe COPD, poorly controlled type 2 diabetes mellitus, and chronic kidney disease stage 3 is scheduled for elective knee replacement surgery. The anesthetist's primary responsibility is to ensure the safest possible anesthetic and perioperative management. Which of the following approaches best reflects the professional and ethical obligations in this complex case? Option A. Proceed with the anesthetic and surgery as planned, focusing primarily on the surgical indication and assuming that standard perioperative care will adequately manage any emergent issues related to the comorbidities. Option B. Administer a general anesthetic with a standard induction and maintenance protocol, without specific preoperative adjustments for the patient's comorbidities, relying on the surgical team to manage any postoperative complications. Option C. Conduct a comprehensive preoperative assessment, including optimization of the patient's diabetes and renal function, consultation with respiratory physicians, and development of a tailored anesthetic plan that considers the impact of anesthetic agents and surgical stress on each comorbidity. Option D. Postpone the surgery indefinitely until the patient's comorbidities are completely resolved, as elective procedures are not appropriate for patients with multiple significant health issues. The correct answer is C. Conduct a comprehensive preoperative assessment, including optimization of the patient's diabetes and renal function, consultation with respiratory physicians, and development of a tailored anesthetic plan that considers the impact of anesthetic agents and surgical stress on each comorbidity. Explanation. This scenario presents a professionally challenging situation due to the inherent complexity of managing multiple chronic conditions in a patient undergoing elective surgery. The anesthetist must balance the risks associated with the patient's comorbidities against the benefits of the planned procedure, while also considering the potential impact of anesthetic and surgical interventions on these pre-existing conditions. Careful judgment is required to ensure patient safety, optimize outcomes, and adhere to established clinical guidelines and ethical principles. The correct approach represents best professional practice because it prioritizes a comprehensive, multidisciplinary assessment, and tailored management plan. This aligns with the European Diploma in Anesthesiology and Intensive Care, EDAIC, ethos of evidence-based, patient-centered care. Specifically, it reflects the ethical duty of beneficence and non-maleficence by proactively identifying and mitigating risks. It also embodies the principle of shared decision-making, involving the patient and relevant specialists in the planning process. Regulatory frameworks and professional guidelines within the European context emphasize the importance of thorough preoperative evaluation and risk stratification, especially for patients with significant comorbidities. An incorrect approach that focuses solely on the surgical indication without adequately addressing the patient's comorbidities would be professionally unacceptable. This would represent a failure to uphold the duty of care, potentially leading to preventable perioperative complications and adverse outcomes. Ethically, it breaches the principle of non-maleficence by exposing the patient to undue risk. Regulatory failure would stem from not adhering to established protocols for preoperative assessment and risk management, which are fundamental to safe anesthetic practice. Another incorrect approach that involves a one-size-fits-all anesthetic technique, disregarding the specific impact on each comorbidity, would also be professionally unacceptable. This demonstrates a lack of individualized care and a failure to apply specific knowledge regarding drug interactions and physiological derangements associated with each condition. This approach risks exacerbating existing pathologies and could lead to severe complications, violating the principle of beneficence. A third incorrect approach that prioritizes expediting the surgical schedule over a thorough preoperative optimization of the patient's comorbidities would be a significant ethical and professional failing. This prioritization of institutional efficiency over patient well-being is contrary to the core values of the medical profession and would likely contravene regulatory requirements for patient safety and quality of care. The professional decision-making process for similar situations should involve a systematic approach. 1. Thorough patient history and physical examination, with a specific focus on identifying and quantifying all comorbidities. 2. Review of relevant investigations and consultations with specialists managing the patient's chronic conditions. 3. Risk stratification using validated tools and clinical judgment. 4. Development of an individualized anesthetic and perioperative management plan, including optimization of comorbidities, choice of anesthetic technique, and postoperative care. 5. Clear communication with the patient and the surgical team regarding the risks, benefits, and management plan. 6. Continuous monitoring and reassessment throughout the perioperative period. Question 17. The investigation demonstrates a patient with moderate chronic kidney disease, CKD stage 3B, scheduled for a 2-hour laparoscopic cholecystectomy. The anesthetist is considering intravenous induction agents. Which of the following agents, when administered without specific dose adjustment for renal impairment, poses the least risk of prolonged or unpredictable effects in this patient? Option A, atracurium. Option B, ketamine. Option C, propofol. Option D, midazolam. The correct answer is C, propofol. Explanation. The investigation demonstrates a complex clinical scenario involving a patient with known renal impairment undergoing elective surgery requiring general anesthesia. The challenge lies in selecting an appropriate anesthetic agent that balances efficacy, safety, and minimal organ-specific toxicity, particularly concerning renal function. The anesthetist must navigate the pharmacological profiles of various agents, considering their metabolism, excretion, and potential for accumulation or adverse effects in a compromised renal system. This requires a deep understanding of pharmacokinetics and pharmacodynamics, as well as adherence to established guidelines for anesthetic management in patients with comorbidities. The correct approach involves selecting an anesthetic agent whose primary elimination pathway is not significantly dependent on renal function, or one for which dose adjustments are well-defined and easily implemented in renal impairment. This aligns with the principle of patient safety and minimizing iatrogenic harm, a cornerstone of professional anesthetic practice. Adherence to evidence-based guidelines and a thorough preoperative assessment are paramount. The European Diploma in Anesthesiology and Intensive Care, EDAIC, curriculum emphasizes a comprehensive understanding of drug behavior in various physiological states, including organ dysfunction. An incorrect approach would be to administer an agent that is predominantly renally excreted without appropriate dose modification, or to ignore the patient's renal status altogether. This represents a failure to apply fundamental pharmacological principles and a disregard for patient safety, potentially leading to prolonged anesthetic effects, delayed recovery, and increased risk of adverse events such as postoperative delirium or respiratory depression. Such an oversight would be considered a breach of professional duty of care and could contravene ethical guidelines related to patient management. Another incorrect approach might involve relying solely on generic dose recommendations without considering the specific degree of renal impairment, failing to individualize anesthetic care. The professional reasoning process in such a situation should involve a systematic evaluation of the patient's comorbidities, a review of the pharmacological properties of available anesthetic agents, consultation of relevant anesthetic guidelines and drug formularies, and a clear communication strategy with the patient and surgical team. The anesthetist must weigh the risks and benefits of each potential agent, prioritizing those with a favorable profile in the context of renal impairment. Question 18. Upon reviewing the preoperative assessment of a 72-year-old male scheduled for elective abdominal surgery, you note a history of mild exertional dyspnea and a smoking history of 40 pack years. He denies any recent exacerbations of cough or sputum production. Which of the following approaches to pulmonary risk assessment is most aligned with best professional practice for this patient? Option A. Rely exclusively on the patient's subjective report of mild exertional dyspnea as the sole indicator of pulmonary risk, without further objective investigation. Option B. Proceed with surgery as planned, assuming the patient's mild dyspnea is age-related and not indicative of significant pulmonary risk given his denial of recent exacerbations. Option C. Focus solely on the invasiveness of the planned abdominal surgery, assuming this is the primary determinant of perioperative pulmonary risk, and proceed with standard anesthetic management. Option D. Conduct a comprehensive pulmonary risk assessment utilizing validated scoring systems, and consider pulmonary function testing if indicated by initial findings, alongside a detailed respiratory history and physical examination. The correct answer is D. Conduct a comprehensive pulmonary risk assessment utilizing validated scoring systems and consider pulmonary function testing if indicated by initial findings, alongside a detailed respiratory history and physical examination. Explanation. This scenario presents a common clinical challenge in anesthesia and intensive care, assessing pulmonary risk in a patient undergoing elective surgery. The professional challenge lies in balancing the need for surgical intervention with the potential for perioperative respiratory complications, which can significantly impact patient outcomes and resource utilization. Careful judgment is required to accurately stratify risk and implement appropriate preventative strategies, adhering to established guidelines and best practices. The correct approach represents best professional practice because it involves a comprehensive, evidence-based assessment of multiple risk factors, aligning with the principles of patient safety and individualized care. This approach prioritizes objective data and validated scoring systems, such as the American Society of Anesthesiologists, a SAF physical status classification system, and specific pulmonary risk indices, to guide decision-making. It also emphasizes the importance of preoperative optimization of respiratory function and the selection of appropriate anesthetic techniques and postoperative management strategies tailored to the patient's identified risks. This aligns with the overarching ethical and professional duty to provide high-quality, safe patient care as expected within the European context of medical practice and training. An incorrect approach that relies solely on the patient's subjective report of dyspnea without objective assessment fails to acknowledge the limitations of subjective reporting and the potential for significant underlying pulmonary pathology that may not be immediately apparent. This could lead to underestimation of risk and inadequate preparation, potentially resulting in perioperative respiratory events. Ethically, this represents a failure to conduct a thorough assessment and provide appropriate care. Another incorrect approach that focuses exclusively on the planned surgical procedure's invasiveness, disregarding the patient's individual pulmonary status, is also professionally unacceptable. While surgical invasiveness is a risk factor, it must be considered in conjunction with the patient's physiological reserve. Ignoring the patient's specific pulmonary condition is a deviation from best practice and could lead to adverse outcomes. This approach fails to adhere to the principle of individualized patient care, A third incorrect approach that involves proceeding with surgery without any specific preoperative pulmonary risk assessment, assuming the patient is otherwise healthy, is a significant regulatory and ethical failure. This demonstrates a lack of due diligence and a disregard for established protocols for perioperative risk management. It exposes the patient to unnecessary and preventable harm, violating the fundamental principle of primum non nocere. First, do no harm. The professional decision-making process for similar situations should involve a systematic approach. 1. Thorough history and physical examination, with a specific focus on respiratory symptoms and signs. 2. Review of relevant investigations, including pulmonary function tests if indicated. 3. Application of validated risk assessment tools and scoring systems. 4. Consideration of the planned surgical procedure and anesthetic technique. 5. Discussion of risks and benefits with the patient, involving them in shared decision-making. 6. Development of a tailored perioperative management plan, including preoperative optimization, intraoperative monitoring, and postoperative care. 7. Continuous reevaluation of the patient's status throughout the perioperative period. Question 19. The risk matrix shows a patient with a history of severe, exercise-induced bronchospasm undergoing elective knee arthroscopy. Which anesthetic approach best balances the need for surgical access with the imperative to minimize perioperative respiratory compromise? Option A. General anesthesia with a standard induction and maintenance protocol, relying on intraoperative bronchodilator administration if bronchospasm occurs. Option B. Spinal anesthesia with sedation, accepting the potential for airway compromise if sedation is deepened. Option C. General anesthesia using a volatile anesthetic agent and a laryngeal mask airway, with routine administration of intravenous bronchodilators. Option D. General anesthesia with careful titration of intravenous anesthetics, avoidance of airway irritants, and preoperative administration of inhaled bronchodilators and corticosteroids. The correct answer is D. General anesthesia with careful titration of intravenous anesthetics, avoidance of airway irritants, and preoperative administration of inhaled bronchodilators and corticosteroids. Explanation. The risk matrix shows a patient with a history of severe bronchospasm undergoing elective knee arthroscopy. This scenario is professionally challenging due to the inherent conflict between the need for surgical intervention and the significant risk of perioperative respiratory compromise. Careful judgment is required to balance the benefits of anesthesia and surgery against the potential for life-threatening airway events. The correct approach involves a thorough preoperative assessment, optimization of the patient's respiratory status, and the selection of an anesthetic technique that minimizes airway irritants and facilitates bronchodilation. This aligns with the European Diploma in Anaesthesiology and Intensive Care, EDAIC, Principles of Patient Safety and Evidence-Based Practice, which mandate a proactive approach to managing known risks. Specifically, guidelines emphasize the importance of tailoring anesthetic plans to individual patient comorbidities, and the need for a multimodal approach to airway management and bronchodilation in at-risk individuals. An incorrect approach would be to proceed with a standard general anesthetic without specific preoperative optimization or modification of the anesthetic technique. This fails to acknowledge the elevated risk of bronchospasm and could lead to severe perioperative respiratory distress, potentially violating the duty of care and the ethical obligation to minimize harm. Another incorrect approach would be to solely rely on bronchodilator administration intraoperatively without adequate preoperative preparation, as this is a reactive rather than a preventative strategy and may not be sufficient to manage a severe bronchospastic episode. A third incorrect approach would be to opt for a technique that inherently increases airway irritancy, such as the use of volatile anesthetics with a laryngeal mask airway in a patient with a history of severe bronchospasm, without a compelling clinical indication and robust mitigation strategies. This demonstrates a failure to apply best available evidence and patient-specific risk assessment. Professional decision-making in such situations requires a systematic process. 1. Comprehensive risk identification and stratification, as presented by the risk matrix. 2. Thorough patient assessment and optimization of comorbidities. 3. Consideration of multiple anesthetic modalities, weighing their respective risks and benefits in the context of the individual patient. 4. Collaborative decision-making with the surgical team and patient where appropriate. 5. Development of a detailed perioperative management plan, including contingency strategies for potential complications. Question 20. Examination of the data shows a patient in the intensive care unit with a heart rate of 110 beats per minute, blood pressure of 95/60 mmHg, respiratory rate of 22 breaths per minute, and oxygen saturation of 94% on 4 liters of oxygen via nasal cannula. The patient underwent major abdominal surgery 48 hours ago and has a history of hypertension. The patient appears restless but is able to respond to verbal stimuli. Which of the following interpretations and subsequent actions best reflects a comprehensive and clinically appropriate assessment of this patient's vital signs within the context of their presentation? Option A. The heart rate and blood pressure are slightly elevated and decreased respectively, but within acceptable limits for a post-operative patient, and no immediate action is required beyond routine monitoring. Option B. The oxygen saturation is below the target of 96%, indicating significant respiratory compromise, and the patient should be immediately intubated and mechanically ventilated. Option C. The vital signs suggest a developing state of hypoperfusion and potential early sepsis, necessitating a thorough reassessment of fluid status, consideration of vasopressor support, and prompt investigation for sources of infection. Option D. The patient's restlessness is likely due to pain, and the primary intervention should be the administration of a strong opioid analgesic to improve comfort and reduce heart rate. The correct answer is C. The vital signs suggest a developing state of hypoperfusion and potential early sepsis, necessitating a thorough reassessment of fluid status, consideration of vasopressor support, and prompt investigation for sources of infection. Explanation. Scenario analysis. This scenario presents a common yet critical challenge in intensive care, interpreting vital sign trends in a patient with a complex underlying condition. The challenge lies not just in recognizing abnormal values, but in understanding their potential implications within the context of the patient's specific physiology and treatment. A superficial assessment can lead to delayed or inappropriate interventions, potentially worsening patient outcomes. The need for rapid, accurate interpretation and decisive action under pressure is paramount. Correct approach analysis. The correct approach involves a systematic, holistic assessment of the patient's vital signs in conjunction with their clinical presentation and known medical history. This means not just looking at individual numbers, but observing trends, considering the interplay between different parameters, e.g., heart rate and blood pressure, and relating these findings to the patient's baseline and expected physiological responses. This aligns with the EDAIC emphasis on comprehensive patient management and evidence-based practice, requiring clinicians to synthesize information from multiple sources to form a clinical judgment. It reflects the ethical obligation to provide competent and diligent care, ensuring that interventions are guided by a thorough understanding of the patient's condition. Incorrect approach is analysis. One incorrect approach would be to focus solely on a single abnormal vital sign without considering the broader clinical picture. For example, reacting solely to a slightly elevated heart rate without assessing for other signs of distress or hypovolemia could lead to unnecessary interventions or a misdiagnosis of a more serious underlying issue. This demonstrates a failure in comprehensive assessment, a core tenet of good medical practice, and implicitly required by the EDAIC standards for safe patient care. Another incorrect approach is to dismiss a trend of deteriorating vital signs because individual values have not yet crossed a predefined critical threshold. This shows a lack of proactive clinical reasoning and an adherence to a rigid, reactive approach rather than a dynamic, anticipatory one. The ethical failure here is a potential delay in recognizing and addressing a worsening condition, which could be construed as a breach of the duty of care. A third incorrect approach is to rely on automated alerts from monitoring equipment as a substitute for clinical judgment. While alerts are valuable, they are designed to flag potential issues, not to provide a definitive diagnosis or treatment plan. Over-reliance on these systems without independent clinical verification can lead to alarm fatigue or misinterpretation of the patient's true status, representing a failure to exercise professional responsibility and critical thinking. Professional reasoning. Professionals should approach vital sign interpretation with a framework that prioritizes understanding the patient as a whole. This involves 1. Establishing a baseline, 2. Observing trends over time, 3. Correlating vital signs with the patient's clinical presentation, e.g., level of consciousness, skin perfusion, respiratory effort, 4. Considering the patient's underlying pathology and current treatments. And 5. Anticipating potential complications. This systematic process allows for timely and appropriate interventions, ensuring patient safety and adherence to the highest standards of care expected in intensive care medicine.